Hello and good afternoon. My name is Mohammed Tola, and I'm going to be presenting my quality improvement project regarding ICU medication reconciliation. So, a little bit background about this project. We noticed a pattern amongst our patient population that were taking bronchodilators or gastric acid suppression medication without any corresponding diagnosis. Oftentimes, on interview, these patients were unable to recall ever partaking in pulmonary function tests or undergoing any endoscopic procedure to warrant these respective medications. Of note, most of these patients that were on these medications did have a history of ICU stay at some point in their lifetime. We postulated that there may be a correlation between the past ICU stay and their medication reconciliation. So we come up with this QI project with the objective to identify potential for medication-related adverse events and to optimize medication reconciliation upon discharge. So we did a retrospective chart review from 13 hospitals in North Texas HCA division, including Medical City Fort Worth, and we gathered the data from July 2019 to December 2019. The inclusion criteria for the study was to include patients with septic shock, acute hypoxemic respiratory failure, intracranial hemorrhage. The exclusion criteria for this study was acute COPD exacerbation, history of COPD or diagnosis of COPD on discharge, asthma, GERD, or history of GI bleed, peptic ulcer. So we developed this algorithm to maximize sorting patients with the highest likelihood to require mechanical ventilation in the ICU settings. So we had 23,204 patients included in our analysis, out of which 387 were excluded because they did not meet our inclusion criteria. Uh, Upon discharge, 26.8% patients were discharged on PPI, 33.92% patients were discharged on bronchodilators, 27.7% patients were discharged on steroids, and 8.39% patients were discharged on S2 blockers. Uh, Also, one interesting thing to note that 100% of the patients that were ventilated, they received bronchodilators. So our analysis basically demonstrated substantial usage of bronchodilators and acid suppression therapy in a critically ill ICU patient. And recent evidence-based studies, they have concluded that initiation of GI bleed prophylaxis is basically unnecessary. It's not required all the time. Studies on long-term keeping or long-term usage of these medication can cause renal side effects and osteoporosis. uh, there's also an increase in the cost burden to the healthcare system when prescribing bronchodilators or PPIs on discharge. To conclude my conversation today, I would like to summarize that our analysis demonstrated that a significant portion of the patients which are being discharged on steroids, gastric acid suppression medications, or bronchodilators may or may not need them. Given long-term side effects of steroids and especially PPIs, we should carefully consider patients and before starting these medications in the ICU. We also believe that multidisciplinary approach to medication reconciliation during ICU downgrade to prove beneficial in preventing such occurrences. Also, refining mechanical ventilation order set with end dates for medications could mitigate unnecessary continuation of medications and downgrade or discharge patients from the ICU. Thank you so much.